All right, good afternoon, everybody. Hello. So we're going to go ahead and get started so that we have enough time to get through. We have 5 different cases that hopefully we'll be able to get through all of them. I'm Christopher Hurt. I'm an assistant professor at UNC in the Division of Infectious Diseases. And one of my hats at UNC is working with I direct the clinic's HIV and Hep C co-infection treatment program. And also up here with me is my colleague from Duke, Dr. Susanna Naggie. Dr. Naggie is an associate professor at Duke in infectious diseases and does most of her work clinically out of the VA Medical Center in Durham. And she's well known to many of you and increasingly well known around the country for her expertise in Hep C. So we're very lucky to have her here today. So we're going to go through cases. This is meant to be relatively informal. Susanna has not seen the cases before, so this is an exciting I promise there's nothing like shocking or concerning on any of these cases.
No Zika virus, right?
No, there's no Zika wannabe cases on this, no. So these are disclosures, which will be in the slide deck at the end. So our first case is Sam. Sam is a 57-year-old African-American gentleman who has Blue Cross Blue Shield for insurance. This is one of the history questions now for everybody is what's your insurance status? He's treatment naive, and he's genotype 1. So in 2005, he had genotyping done that showed genotype 1, and that's the only genotype that he's ever had in the system. His HIV RNA, or HCV RNA, was 270,000 in October of last year. And he had elastography done around that same time that had F3. From an HIV perspective, he's pretty well controlled. He's on a combination of elvitegravir, cobicistat, FTC, and TDF. I'm not supposed to say trade names, although now I really wish I could. His CD4 650 is 22%, and his HIV RNA has been not detected and been stably undetected for quite some time. His concomitant medications, the standout really probably is buprenorphine naloxone. So he's in recovery from opioid addiction, and also pantoprazole and pravastatin on that list as well. His labs are okay looking. Creatinine of 0.79, AST and ALT are elevated but not super high, 80 and 82 respectively. Platelets of 216. His albumin is good, INR is 1. He's Child-Pugh A, and his APRI and FIB4 scores are there. So what would you do, Dr. Naggie?
I would treat as Hep C.
Okay, good. So we're on the same page.
Is this working?
Yeah.
I don't know. So I think that's why I'm here.
Yeah.
So I think, and I have a one-track mind, everyone will realize that. For me, it's all about the liver, it's all about the Hep C, and I don't really think about much else. I always have a disclosure that I'm a zealot. I believe everyone should be treated for their hepatitis C, so I'm not a big fan of passing on therapy or delaying therapy in any way, shape, or form, and I think increasingly the data suggests that regardless of stage of liver disease, there's benefit to cure of HCV, and in fact that it's cost effective even to cure patients who do not have severe liver disease at the time of their viral eradication. So I think when it comes to an HIV-infected patient in particular, obviously drugs and drug interactions are the critical difference really between a patient with HIV and a patient without HIV. We'd like to believe that patients with HIV should all get access to therapy. However, I, and I'm sure many of the providers in the room, have HIV-infected patients who have been denied access to treatment, which has been a major issue. So Blue Cross Blue Shield, I think, like many other insurers in North Carolina, do not necessarily view HIV as a special population, and therefore those patients do not necessarily get access, regardless of stage of liver disease, which is what I think most of us would argue should be happening. Mm-hmm. So I think when you go through this, there are a couple of things to think about. So one is the HCV genotype. So obviously we still to this day treat different genotypes with different medications. So he is a genotype 1, and in fact we make different decisions not just based on genotype 1 but also on the subtype of genotype 1. So we would need to take that a step further depending on what regimen we chose to determine whether this is a patient who's a 1A or a 1B. And this is something that we really didn't think about back in the interferon days, but now with direct-acting antivirals, there are differences in potency and in barrier to resistance for a 1A regimen versus a 1B regimen. And that comes into play extensively when you talk about protease inhibitor-containing regimens in particular. So I have a general, you'll see me do this a lot, I have a lot of rules of thumb. Those people who are in my clinic and work with me clinically and in research know that I have a lot of rules of thumb. What that means is I might not have a lot of data to guide it, but my gut tells me what the right thing to do is. And one rule of thumb in HCV is that if you have a protease inhibitor-containing regimen, generally speaking with our current PIs, you will see a difference in response to therapy between a 1A and 1B, and that is generally because of a different barrier to resistance between 1As versus 1Bs. 1Bs having a higher barrier to resistance, 1As having a lower barrier to resistance, so you may see more impact with regards to resistance, and therefore higher relapse rates in 1A patients in particular. So that's something that we may want to know more about, depending on which regimen we choose. If it's not a protease inhibitor-containing regimen, the difference in variation between a 1A and 1B is much less, and therefore has not yet kind of had significant clinical impact, and that we would make a different recommendation on therapy.
So do you think that with decladisvir, sofosbuvir, and velpatasvir coming, is there going to be a point where we don't care about genotypes anymore? I mean, that you just Hep C antibody and RNA positive and treat?
Yes, I do think that there will be a time when that happens, absolutely. I think part of that may depend on what these various pan-genotypic regimens get approved for. And I think we also all recognize that, so if you think about decladisvir, sofosbuvir, for example, which some people argue is the kind of first pan-genotypic regimen that was approved by the FDA. And what we mean by pan-genotypic is that it means that it is active against every genotype. So if you take a step back, remember that HCV, I always tell my patients, comes in six different flavors. There is a now genotype 7, but clinically it is less relevant. But we have 6 different types of HCV, 1, 2, 3, 4, 5, and 6. And I tell my patients, these are like siblings, right? So genetically they are similar, and usually they vary by about 30% of their genome in terms of their genetic difference. And that does play out when it comes to pathogenesis. It plays out in particular for genotype 3, for example, where genotype 3 tends to cause more significant fatty liver disease. All viral hepatitis can cause fatty liver disease, but in particular, genotype 3 is more likely to do that. And it also plays out in how a direct-acting antiviral potency, how high a potency is for a direct-acting antiviral. The first antivirals that came out were really more potent against genotype 1. They were directed towards genotype 1 based on the laboratory methods that we had for understanding the life cycle of the HCV virus. So as time has progressed and development has changed to really focus on developing true pan-genotypic regimens, we've gotten better and better. But if you look at for example, decladisvir, sofosbuvir, genotype 2 and 3 is where we have either 1, less data, or 2, clearly decreased efficacy. So genotype 3 in particular with this regimen in patients who have cirrhosis, it does not perform very well, right? So in that setting, you would argue that you still want to know who that genotype 3 patient is. When you move into the soft velpatasvir regimen, so this is, and I should have mentioned that decladisvir, sofosbuvir, and soft velpat are both NS5A nuke-containing regimen. So I would use the terminology, this is a protease inhibitor sparing regimen, and these are NS5As in combination, in this case, both with the same nucleotide polymerase inhibitor, which is called sofosbuvir. So in that setting, if you look at the data, again, patients who are genotype 3 in particular, if you look at their phase 3 program, it's quite exceptional. But genotype 3 patients, in particular patients who are treatment experienced and patients with cirrhosis, have a higher relapse rate. So for me as a clinician, I want to know who that patient is because I'm probably going to do something different for them, maybe even than what the FDA recommends that I do to try to optimize that patient's therapy. I think we've learned pretty well that there are 2 things that can optimize patient's therapy, and by that I mean decrease relapse. What does relapse mean? Relapse means a patient takes a drug, While they're on that drug, the virus suppresses and remains suppressed throughout the entire course of therapy. But when that drug is removed, because remember, for HCV, this is finite treatment. It's not like an HIV where you take it for the rest of your life. This is a finite course of therapy, 8 weeks, 12 weeks, 24 weeks. When you remove that drug, the virus comes right back. We call that relapse, right? So ultimately, I think we've learned that to decrease relapse, you can do two things. You can extend treatment, prolong the course of therapy, or you can add ribavirin, which is kind of like the underdog that refuses to go away. It's dirt cheap, and yet it clearly decreases relapse via mechanisms that no one is really all that clear on. There's a lot of hand-waving that goes on panels when people start talking about how ribavirin works. But we do know that happens, and clinically, I may often add ribavirin to a regimen that's FDA approved without ribavirin because I want to optimize treatment for that patient. Maybe they have they have a greater BMI than patients who are allowed in studies. Maybe they have multiple risk factors that one-on-one don't seem to play a role in DAA therapies, but when all combined probably do, right? So to me, even with the soft Velpat regimen coming, I'm going to argue that there should still be a recommendation for genotype testing, at least in a high-income country. Low and middle income countries where the reality is if you can't get genotype testing, then you can't get treatment, I'd probably say those patients can move forward, and you're going to have to just risk on a population level some patients who fail. But I think in a high-income country like in the United States, that still remains very relevant. Yeah. Moving forward, hopefully we'll have regimens where that isn't true. But I completely agree that for now that is not the case.
So what would you do in terms of his ARVs so the top kind of things that you're considering for treatment for him, assuming, say, he's let's make it 1B.
He's a 1B.
He just for grins.
Yeah.
So what would you be thinking, and what would you be thinking about his ARVs in that situation?
So like I said, if you want to really kind of double down on things and really make a decision on his regimen, what you're going to have to look at is the medications that he's on, right? And if you want to start with his antiretroviral, that's a pretty good one to start with because it is generally contraindicated with a vast majority of the DAAs that we currently have available. So it would be contraindicated with the current AbbVie regimen, which is the paratoprevir, ritonavir boosted, ombidisvir, Desabovir regimen that I will from henceforth refer to as PROD. I apologize to anyone who cringes when I say that, but it's a much easier to say. So it's contraindicated with the PROD regimen. It's contraindicated as well with the Merck elbasvir-grazoprevir regimen, and that is in large part because of the boosting component, the cobicistat that's in this. I think there's another rule of thumb that I would use, which is that HCV protease inhibitor containing regimens tend to have more drug interactions, I know that's shocking for this audience, than a non-protease inhibitor containing regimen. So this is just like in HIV. In HIV, the protease inhibitor containing regimens, especially those that require ritonavir boosting, are going to have more drug interactions. So that just becomes an issue. And I have a slide in my talk this afternoon that'll show you the contraindicated ARVs, and when you have a PI containing regimen, there's just going to be more of those. And that just gives you fewer options as an HIV provider. So then that narrows you down pretty quickly, right? So samipravir, sofosbuvir, another regimen that's available, but it's a protease inhibitor containing regimen, again, contraindicated. So now we turn to the kind of the non-PI containing regimens. You're thinking of decladisphere, sofosbuvir, ladipasvir, sofosbuvir, right? And in that setting, technically decladisphere, sofosbuvir would be an option. The issue for this regimen and the ladipasvir, sofosbuvir regimen is that ladipasvir has an interaction with tenofovir. It increases the exposures, and we'll talk about this in my talk as well, to a level that is 30 to 40% higher than what you get with tenofovir as a boosted regimen alone, which is already 30 to 40% elevated from what you get if it's a non-boosted regimen, right? So it's a pretty significant increase. We're talking about somewhere in over 6,000 AUC range.
For TDF, right?
For TDF, yeah. Which is what that says right there. Yeah,
yeah.
So that's an issue. Now, we could take a step back and say that velpatasvir, which is the same company that makes ladipasvir, sofosbuvir, is now making the soft Velpat regimen. It'll be approved at the end of June. And there's a very similar interaction between their NS5As, ladip or vel, and tenofovir, TDF tenofovir, right? So that phase 3 study was just presented at the European Liver Meeting, and they included COBI-containing regimens with TDF, so boosted regimens, both either as a ritonavir-boosted regimen or as a COBI-boosted regimen. And in fact, out of 53 patients in that study that were on a tenofovir-boosted regimen, there was no sign of toxicity. So That suggests, in fact, for me, that this is likely now a regimen that you could move forward with the Ledipasvir soft regimen as well, since I don't view them a whole lot differently in terms of the increased tenofovir exposure. But at this point, you'd still be off the reservation in the sense that the FDA recommendation does not suggest that is recommended, and neither does the AAS or the IDSA guidelines at this point. Although I think that is likely to change based on those data, to be honest with you. And based on what the FDA says regarding the safety of that regimen with boosted therapies, which should be recommended as safe. So I think in this case, you're looking at a PI-sparing regimen. And I think you could, if you want to stick by the package inserts, you're going to go with the DAC-SOF regimen. But how many people in here have been successful in getting DAC-SOF for a genotype 1 patient? How many of you have tried? So a couple of hands. I mean, I've tried multiple times. And thankfully, when DAC got the genotype 1 indication, that made it easier. But I think you have to recognize cost here. In terms of wholesale cost of the DAC-SOF regimen, you're talking about, what, $150,000 versus the WAC cost for the lead-soft regimen, which is $94,000. So there is a pretty significant difference. Is that what payers are paying? No. But as you all know, we don't know what goes on behind the curtain. We have no idea what the insurers are paying for these drugs, and so you have to recognize that it likely is a significantly increased cost, which just means a payer's going to fight you pretty hard on it. Yep. So I think that's kind of where you stand, and the cheaper regimen is going to be the regimen where you're assuming a little bit more risk as a provider by going what would consider to be off-label at this point in time. Because the data is so fresh.
So he's on pantoprazole too.
Right.
So just to make it more complicated.
Yes, exactly. Yeah. And I think this is going to kind of be rehashed in my talk this afternoon. But when you look at these regimens, so again, declatosphere has drug interactions with multiple medications, but the one bonus of declatosphere, and as a whole, again, rule of thumb, NS5As tend to have less CYP, 3A4 and or P450 interaction. So as a whole, not always, but as a whole, PIs have a lot more P450 risk, and NS5As tend to have less P450 risk. So as a whole, with drug interactions, the NS5A containing PI-sparing regimens usually a little easier to work with when you have patients on multiple drugs, right? The issue with DAC is it has interactions. It has interactions with efavirenz. It has interactions with atazanavir. But because it's not in a fixed dose combination, you can change the dose. So it comes as a 30 and a 60, and you can either decrease it to 30, the base dose is 60, decrease it to 30 or increase it to 90, and that allows you to work with this, whereas fixed dose combination tablets, you can't just cut them in half, right? It doesn't work that way with these antivirals, or at least I would not recommend it, although it's amazing the things that patients try at home when you don't specifically tell them what not to do. So I think from that perspective, it does give you a little bit more flexibility. Yep. So now take a step to the pantoprazole. So how many people recognize the issue of acid-suppressing medicines and lead-soft? Yeah, so for particular tables where there's a raise of hand. So this is an issue where how many people in this room is on an acid-suppressing medicine? Oh, there's no way.
How about anxiolytics also?
No HIPAA here. Yeah, so I'm certain there are more of you that are on some sort of acid-suppressing medicine, maybe not with regularity, but as you know, these are over-the-counter medications, and they are rampant. In fact, if you look at many studies, it's 40-50% of people report taking one in the past week, right? So this is a big issue, and ultimately what we know about acid-suppressing medicines, in particular proton pump inhibitors and ledipasvir, is if you don't take it at the lowest dose and in a fasted state at the same time with the PPI and the ledipasvir, you essentially decrease exposure by 90%. And as you can imagine, it's difficult for a patient to stick to the fasted state. I mean, you could even ask for a show of hands, how many people understand what a fasted state is? Like, everyone understands what it means to have not eaten, but how long do they have to wait to eat to be still considered fasted state, right? And there's all kinds of debates about what that means. So this is difficult for patients to follow. And what I say is if you do that, you are taking a really expensive placebo pill, basically, right? And that's a major issue. And I think many of us had concerns about this interaction. These drugs were not allowed in the phase 3 trials. The FDA came out based on additional healthy volunteer data saying that as long as you did 20 milligram equivalent of a PPI and you took it fasting at the same time, then you're probably okay. That being said, from the large Target study, so I know UNC and Duke are both participants in the Target. This is a multi-center cohort registry looking at the largest cohort of HCV-infected patients that are receiving DAAs as part of clinical care. And this was the first reported AASLD that reported that patients who simply had evidence of a prescription for a PPI had a higher relapse rate. They didn't know what the doses were, how the patient took it, or anything like that. But I think ultimately that suggested that this is an issue. Maybe it's because patients weren't taking it correctly. Maybe it's because they were taking it and the providers didn't know. Or maybe it's because a patient who's chronic acid suppression has a very different gastric mucosa and ability to absorb a drug than a patient who's a healthy volunteer and gets dosed by a PPI for 3 days in a row, right? So I think these are issues, and in my clinical practice, I discontinue PPIs and H2 blockers. I give patients a period of 4 weeks off, and I find out whether or not they have breakthrough. It's amazing to me the number of patients who are on these drugs, by the way, that are crazy expensive, and they don't know why. Who started it? I don't know. How long have you been taking it? No idea. How much money does that cost? I mean, a crap load of money, right? Let's get into drug cost and discussing how many millions and millions of dollars are spent on PPIs every year. So my first thing is to take patients off, and shockingly, 9 out of 10 do just fine. The other really interesting thing that I've learned is the other one just started eating mustard, and they said that worked just fine too. So how many people in here knew mustard was really good for heartburn? Aha, yeah. So there's just like a southeastern thing. I tell my colleagues in the northeast, they're like, "You do what in Durham, North Carolina?" But I tell you what, I started recommending it to my patients, like no harm. And amazingly, some patients feel like it works. So my first step is to take them off of it, see if they have breakthrough. If they do have breakthrough and require something, I try to start back an H2 blocker, which I think I feel more comfortable with. Has to be dosed 12 hours apart, still a limitation in the amount that you can use, or I look for a different regimen. I feel that strongly. My MO in treating patients with HCV is to have no relapse. That's my motto in my clinic, and I think we all feel that way because there's nothing worse than telling a patient, especially in the DAA era where patients think that DAAs, like, they're going to know how to ride a horse, they're going to have, like, fancy vacations. Like, you look at the commercials and it's crazy, and they have the highest expectations of these drugs. So to them, relapse is not really in the commercial. Right? 99% sounds like that's someone else's problem. So telling a patient that they've relapsed is horribly painful. For the patient, for sure, and I would argue for the provider, there's nothing worse than telling a patient they've relapsed. Luckily, that's only happened for me in patients on clinical trials, but so far, sooner or later, it's going to happen, right? And you have to optimize this in every way that you can. Yeah. So I think that's an issue.
Yeah. One last question for this case. Is there a reason to stop his statin while he's on Hep C therapy?
Yeah, so it depends on this. So I go to Lexicomp and type in every interaction with every one of these regimens because I cannot keep all of this in my head, to be honest with you. So for many of these statins, there are interactions, and I seriously have absolutely no problem with stopping a statin for 3 months. Statins have long-term benefit, not short-term benefit, unless a patient's actively having acute myocardial infarction. And so for many of these patients where there's an interaction, either I dose reduce the statin or I just discontinue it for the 3-month period and then restart it, and that has not been an issue. So I think these all play out into some of the things that you have to think about in starting these patients on therapy.
Great. Okay. Let's go on. Any questions about the first case? Lingering questions? Okay, let's go to the second one.
Do I need to slow down my speech?
All right, this is Mark. He's 28 years old. He's uninsured, which is good news for getting drugs usually.
Yeah, it is. Sadly.
Sadly, yeah. He's genotype 2, and he was diagnosed in 2013. He's treatment naive. His Hep C RNA was 2.1 million in November of last year. He had a typical story of moving from oxycodone to heroin use, including injection use. He's currently in recovery, but had a recent relapse, but is now back in recovery. CD4 is okay, and he's stable on abacavir, dolutegravir, and lamivudine. His concomitant meds are clonazepam and loratadine because it's springtime. And his labs also look okay-ish, so not terrible here. Mm-hmm. So the question that I have for you is, where do you think the field is in people like him have active or recent substance use disorders or an active recovery, early recovery?
Oh, yeah.
Yeah.
Now, this is actually, I think this is I really hope that that this is an area where the increasing research that's being done can really show benefit in something that everyone who does HIV knows very, very well, which is treatment is prevention. This is a virus where inoculum increases risk of transmission. We clearly know that patients who have high viral loads are at risk of transmitting. We know in HIV that if you drop community viral load, you can decrease transmission within that community. And increasingly, I think the CDC in particular and other groups are trying to get data regarding how treatment of HCV can decrease risk of transmission. If you look at the AASLD IDSA guidelines in particular, even back when there was a list of prioritized patients who actively use drugs was identified as a population that should be prioritized because of the potential benefit for decreasing transmission. I'm sure that was like a level C rating, but people on those guidelines felt very strongly that it was important to get that out there. Now we have data for multiple regimens, including the Merck regimen, the lead-soft regimen, the AbbVie regimen in particular that I can think of, that have presented data of patients achieving the exact same cure rates as patients who do not actively use drugs and who are either in substitution programs, active drug use, et cetera. I mean, if you take a step back, even in the interferon days, there was no data to say that a patient who actively used drugs had lower SVR rates. So this thing that insurers are doing, which is denying access to patients who use drugs, is clearly based on judgment of this patient population and is not based in science or biology. So I think this is an issue where the more data that we can get to push this agenda, the more important, because these are patients who deserve treatment. Are there reinfection rates? Yes. But we also know very, very clearly that the best way to change behavior is to show people that you're invested in them. Obviously, if a patient is actively using drugs, you wouldn't just treat them without trying to engage them in a program that would help them maintain and achieve abstinence. But that has to be all done together, and I don't think they should necessarily be done sequentially. There's a big push, I think, out there to encourage these patients to get access to treatment. And in my practice, using drugs by no means disqualifies you from being considered a candidate for therapy, as long as you can engage and as long as you're willing to discuss and engage in lower risk behaviors in terms of drug use.
So do you do specific harm reduction counseling with people, or do you have somebody in your clinic that helps with harm reduction
Yes, I
counseling?
have a fantastic social worker named Keith McAdam. I'm not sure if he's here, but I'll give him a shout out anyway, who does this. So Keith and I are like this, and I know his personal cell phone. No, just kidding. But yes, I think you do have to. I think as a provider, that's part of your responsibility, and that's really how you help the patient, right? But I can tell you the number of patients who have active drug use, severe psychiatric disease, when you tell them how much money this is and you tell them that you're willing to spend that money on them because you think it's important for them, they actually take that to heart. And I think you can capitalize on that by encouraging them to also then attempt to change their behavior, right?
So the other question I have about this particular person is, so for a long time, we, at least in our clinic, had teed up or queued up people on TDF, FTC, and raltegravir as our holding regimen for ARVs. So with dolutegravir, do you think that they're interchangeable? Is dolutegravir just as good, or is it appropriately interchangeable with raltegravir for that purpose? Or what's your ARV holding regimen? For
from a drug interaction standpoint for HCV drugs. So I think as a whole, that is absolutely true. I mean, we know that dolutegravir does have a bit more P450 risk, but not a huge risk. I think as a whole, many people view them as relatively interchangeable. And in my clinical practice, I do. I think it's certainly the once daily regimen, the fixed-dose combination is something people prefer. Both of them are recommended regimens, but I think you can ultimately assume that they are interchangeable. And increasingly, the companies are doing drug interactions with dolutegravir and raltegravir because they recognize that these are both preferred integrase inhibitor regimens, and that they're regimens that they need to have safety on in terms of providing guidance for HIV providers that are out there taking care of patients that are co-infected.
Okay. So this is a patient that's similar to, but not exactly like one that I just recently saw. And he disappeared on me. This guy disappeared on me, and I was upset about that. And then he turned up in clinic, like magically. Mm-hmm. And I was like, so how did your treatment, did you take your treatment? And he was like,
so you wrote him for HCV treatment, Okay.
And he came back, and he's like, I missed 3 doses through the 12 weeks. It was okay, and I was a little tired, but I was all right. And I wasn't quite sure what to do with him.
Yeah.
So I checked his RNA. So he was at 3 weeks after end of treatment. His RNA was not detected. 3 weeks. So what do you do with somebody who doesn't follow the calendar, who shows up not at a milestone marker for? So like, what's the when do you say you're done?
Yeah. So this is it's a great question, and I think this has happened to all of us, right? Because these DAAs are so safe, they're so much easier to take. The number of we have all expanded our practices to people that we previously maybe wouldn't have treated because of concern, of intolerance, and inability to follow these regimens. But I have many patients where I've written a prescription. They show up once and then they don't show up again. And then they show up at their SVR, their end of treatment plus 12 visit, and they've done great. That is the beauty, to a large extent, of these treatments. If these patients take this drug, they are unlikely to suffer significant consequences, and they're much more likely to be cured even if they can't maintain this close follow-up, right? And I think that actually, if you take a step back even, I think we're grossly over-monitoring these patients. We're so used to monitoring these patients, especially from the interferon days, that I think we're over-treating, we're over-monitoring. We probably could literally dose them and let them go and see them back, and there are now studies trying to look at this kind of low monitoring approach to HCV treatment, because we're probably spending a ton of money that we don't need to be spending. But in this case, my follow-up is actually, I don't see patients at SVR 12, so end of treatment plus 12. There are people who do, but that's just because they like want to know, and I understand that want to know, but at the same time, this costs money. It costs my patients money to come and see me in our hospital-based clinic. That's kind of ridiculous, and they pay like some crazy premium. And so I see patients at end of treatment plus 12. That's where we check SVR 12, sustained virologic response 12, and that is what we call a cure. Now, I think increasingly there was a large SVR registry presented at EASL, which is the European Liver Meeting, that showed that in those patients, 0.6% of patients relapse between 12 and 24. So the way that I do this is, many of these patients have other HIV providers. I don't do much HIV continuity of care at this point. I see them at end of treatment plus 12. I check them. If they're undetectable, I tell them, you are cured. We believe this is a cure as long as you don't get reinfected. I spend that entire visit, the end of treatment and that entire visit, talking about risk of being reinfected. You can get reinfected. Here's how you protect yourself. Here are the things that you have to do to make sure that you don't get this again. And then I usually refer them back to their primary HIV provider, and I tell them, get one more Hep C viral load somewhere after 12 weeks from now. I don't care if it's exactly 6 months post-end of treatment, if it's a year post-end of treatment, but we just want to get one more, because even at 0.6%, it would be a shame to miss those people. Again, in a high-income country, we have the luxury of doing that. In a low and middle-income country, where I'm doing increasing amount of work as well, we just don't have that luxury, and you have to take that 0.6% hit. But I treat every patient as my patient. This is a person sitting here. It's not a population. I manage people, not populations. And so from that perspective, I do that one test.
So you do end of treatment and 12 weeks after, or do you you
I see all of our patients. So the way that I tend to do my follow-up is, and everyone's different. If you look at the guidelines, they say you should get a Hep C RNA at 4 weeks. End of treatment is up to you, but the two that they recommend getting is 4 weeks and then 12 weeks post-treatment, right? So check for cure. And what is the 4 week for? The 4 week is to make sure the patient taking the medicine, right? So there's nothing you're going to do with it specifically, but it does help you know the patient's taking the medication, because they should be undetectable or pretty close to. My motto, I actually check a 2 week. And the reason I do that is, if you have a 12-week regimen and you can tell that they're not taking their meds appropriately at week 4, the horse is out of the barn, the cat's out of the bag, you're a little bit behind the 8 ball, which I don't like to do. So I tend to check a week 2, and then there are less than 15, I don't do it again. So I just move things up a little bit, but everyone has to kind of do what they think is best. I don't spend money on the SVR4 visit, which a lot of people do. That's not recommended in the guidelines. I do a 12-week, and then I send them back to their provider, unless they have liver disease. And this is where, if they have severe liver disease, they continue to need care for their liver disease, and I keep them in my clinic for a period of time.
Okay. And what would you recommend for this gentleman for re-screening? So,
yeah.
Because he may relapse again.
Right, absolutely.
Even despite your efforts for harm reduction.
Yeah, right.
So what's an appropriate interval, and how would you rescreen?
Yeah, so this, I think, the CDC gives relatively clear recommendations on this, but ultimately a patient who's been exposed, who's now cleared because of medical therapy or spontaneous clearance, remember, Hep C antibodies are positive for life. So I've had this happen to a couple of patients who have been treated or cured, and then they call me in a panic because they have new health insurance and their hep C antibody was positive again. And I said, or their provider, I forgot to remind their provider to quit checking their antibody, and they're starting to check it again. And I'm like, it's positive for life. Don't check that. So in these patients who have been exposed, it's an HCV RNA, and I would argue at a minimum, it's once a year. So a patient with ongoing risk should be screened at minimum per the CDC once a year. Now, clearly, if you're following liver enzymes on these patients in particular and their liver enzymes bounce, you're going to want to check that as well. But the reality is, liver enzymes, many patients, remember, especially in HIV, their liver enzymes normalize, and it's pretty impressive how quickly a patient can normalize their liver enzymes. So if you're checking every 6 months, you can easily miss an acute infection. So I think this has to go based on risk and how important you think it is into identifying it. At minimum, it should be an RNA once a year if they have ongoing risk factors. And that's true in all high-risk groups, not just patients who use IV drugs.
Great.
Yeah.
Okay. Questions about the second case? Yeah.
That's a great question. So the question is, how often would you check an alpha-fetoprotein or AFP? So alpha-fetoprotein historically was used as a screen test for hepatocellular carcinoma. We know that patients with liver disease, so an alcoholic with cirrhosis, a hep C patient with cirrhosis, are higher risk for developing hepatocellular carcinoma. It is very different than in hepatitis B. So I always try to talk to my patients about this. Patients with hepatitis B, active hep B, positive surface antigen, regardless of whether or not they are on nucleoside therapy for that, remember, hepatitis B is a carcinogen. In and of itself, regardless of stage of liver disease, you are at a higher risk of developing liver cancer. So patients with active hepatitis B infection, even with the suppressed DNA, need to be screened for liver cancer, right? Patients with hepatitis C, it's very different. The viruses are different. Hep C in and of itself is not a carcinogen, but the fibrosis of the liver is. And so for patients with HCV to get liver cancer, they need to have significant damage in their liver. So generally we say cirrhosis, right? Now, many people recognize that we have no good tests for truly differentiating cirrhosis from severe fibrosis, F3 from F4. So forever, many of us clinically have lumped severe fibrosis together as someone who's at risk, and we've always screened F3, F4s. 5 years ago, AFP and ultrasound every 6 months was the recommended screening by the AASLD, the AASLD for liver cancer in patients with cirrhosis. That changed. I think increasingly the data, I view an AFP like a PSA. Right? The problem with it is it doesn't really help you. It can be elevated in people who have chronic hepatitis. It can be elevated in people who have cirrhosis, and not necessarily in people who have cancer. So you get a patient with cancer who has a normal AFP and vice versa. So AFP screening was removed from the AASLD guidelines a number of years ago. And is no longer recommended in clinical practice. So if you're going to screen someone for liver cancer, then it should be with an ultrasound at minimum every 6 months. What is my clinical practice? As again, rule of thumb, I just make this stuff up, and no one knows the better of it because I practice in a bubble. No, I'm just kidding. So increasingly, if you get an ultrasound on a majority of your patients, what the read that you're going to get back from your radiologist is heterogeneous liver tissue. Decreased sensitivity for differentiating a small tumor. And what they're basically saying is, this is a low sensitive test. We don't feel confident in this. And I feel like this is over 50% of the ultrasounds I get. When I get that, I actually intermittently, so every 6 months I get some picture. It's an ultrasound, and then the next 6 months is a high resolution image, either a triple phase CT scan or an MRI. Because of the decreased sensitivity, right? And the reason for the 6-month time period is because this is based on the doubling time of HCCs, of hepatocellular carcinomas. So we know if there's a small one that you miss, 6 months later, it hasn't grown fast enough that it's going to suddenly be a non-treatable, non-curable malignancy. So the standard of care for liver cancer screening at this point is imaging only, not alpha-fetoprotein. The role for alpha-fetoprotein really becomes when someone has a large tumor and you're going to monitor it in terms of response to therapy or in terms of recurrence of a liver cancer, but not for screening purposes. So I think this really is an issue. Any viral hepatitis can increase AFP, and cirrhosis definitely. So majority of your cirrhotic patients are going to have an AFP in the 40s, 50s, 60s, 70s. and they don't have a cancer, right? So it ends up leading probably to more imaging, more biopsies of things that look abnormal. Patients that have cirrhosis are more likely to have something called focal nodular hyperplasia, which is a non-cancerous lesion. And so, I've seen patients get it's the same as like a PSA, and even of all screening tests, right? Increased risk of medical interventions when not indicated, and AFP probably isn't helping anyone. So no longer recommended. It's a great question.
Great. Other questions about this case? Yeah.
Let's say you treat a patient, it's cured, it's reinfected a year later. Will insurance companies dish out $100,000?
So has anyone yet tried to get coverage for a reinfection? So I don't know the answer to that because as of yet, I have not had reinfections, but we know very well that reinfections occur. In fact, in some specific populations, reinfection rates are as high as 20%. So this is a big deal.
Hold that thought.
Okay.
Yeah.
Okay. But what I can tell you is I don't think we know.
Yeah.
And I'm going to hold that thought and follow the man who just told me to behave.
I'm watching the clock, too. So.
That's right.
All right, so case 3 is Audra. So Audra is a 45-year-old white woman who has hypothyroidism and is on Medicaid. She's treatment-naive, genotype 1B from 2014, Hep C RNA of almost 12 million in the end of 2014, and she got a fibrosure around that same time as well that showed F2. Her HIV is decent, is well controlled. She's not detected, and her CD4 is 530. She's on ritonavir, boosted darunavir, and FTC TDF. She has lots of mutations, an extensive treatment history, and but this regimen sort of has hit the sweet spot, and she's been able to be suppressed for quite some time now. Medications include those that are listed. And her labs are not terrible. So again, pretty okay-ish. The questions that I have about this kind of scenario is where to for the fibrosure. So this question I get a lot of when should we be getting fibrosures on people, and in institutions that have access to FibroScan, which is limited now, what should we be getting and how often and why?
Yeah. So this is something I'm going to talk about as well in the talk, but I think this is great to bring up in more detail. So I think this is a tough one, right? So let's just, for those in the audience who don't do this every single day, so liver biopsy used to be our way of staging patients' liver disease. And back in the day, the reason we staged patients' liver disease in particular was to determine their risk of developing cirrhosis and therefore the benefit to therapy, because therapy was horrible, right? It didn't work very well. So you didn't really want to give interferon ribavirin to every person with hepatitis C. You really wanted to give it to the people who had the most to gain, meaning that they clearly already had enough damage that they were going to continue to progress if you didn't do something about it, right? Well, now we have these phenomenal therapies. They're really safe. They're highly effective. So why wouldn't you treat everyone? So that we no longer really have the question of whether we're going to use it to make a decision on treatment, although insurers are specifically requiring this. They're using these lab tests. That makes me laugh because the way that they're using the lab test, they're as good as a 50-50 coin flip. So they don't know what they're doing, yet they're requiring providers who actually do know what they're doing to follow these ridiculous recommendations. I hope there's someone from Blue Cross Blue Shield in the room. Meet me out back later. No, I'm just kidding.
They paid for this room, probably. So.
They paid for this room. Yeah, I might just be a little bit of an angry, not-so-youth when it comes to this situation. But ultimately, these tests do not perform well in differentiating stages of liver disease. So you can't use an APRI score, a FIB4, or a fibrosure to know if someone's F1, F2, F3. They are better if you want to say, do you or do you not have cirrhosis? In fact, they can get up to almost a 90% chance of being correct. Means you have a 10% chance of not being correct, but if you want to make a difference between, say, F2 and F3, what does North Carolina Medicaid require? They have to be F2, right? So I have a number of patients whose fibrosure comes back and it says F1 to F2, and they're like, nope, sorry, that is not F2, that's F1.5 apparently. So, and what I tell them is you do realize that this test is as good as a coin flip. You might as well flip a coin and make a decision based on that, and that's how you're denying access to treatment, that's how they're denying access to treatment. But as a provider, you also have to understand that a fibrosure comes back with a report, F2, it can't tell you that patient's F2. I mean, that patient's a 60% chance of being an F2 and a 40% chance of not being an F2. And as clinicians, we would never choose to use a test to make a medical decision based on that, right? So I think these all have to be taken with a grain of salt, and you have to use them asking the correct question. The correct question is, do you or do you not have cirrhosis? Then you have a 90% chance of being correct. If you ask them, do they have F2, you have a 60% chance of being correct, right? So now the one thing you can do is a FibroSure is a different test, right? So this is a commercial test. It utilizes 5 different variables into a equation, and some of those variables are based on blood tests that you can get that is supposed to reflect turnover of matrix in the liver tissue, okay? It is not reflected in an APRI or a FIB4, which is specifically based on liver enzymes and platelet count. So they do reflect 2 different tests. So I do think concordance is important. So if you have 2 tests that aren't worth much, but if you use them together and they're concordant, it does increases your confidence in the test. And there are studies that say that it does actually increase your ability to get the right answer, right? I prefer one of those blood tests and a FibroScan because, again, they are 2 different technologies, so I feel more confident in that. But the reality is a FibroScan, which is a non-invasive, I say ultrasound technology, it's not really an ultrasound, but that's how, for patients, it's easier to understand that. And it has the same issues. So if you want to say F2 versus F3, it's not very good. If you want to say cirrhosis, yes, no, it's quite good. And the reality is clinically, what we really care about clinically is do you or do you not have cirrhosis, right? That's because patients with cirrhosis have to be managed for their cirrhosis for the rest of their life, even once they're cured. And depending on the regimen, we treat patients with cirrhosis differently. So I think F2, I look at that and I kind of just chuckle because I have no idea what that patient really has. Now, if I look at their platelet count of 216, their albumin of 3.9, I can tell you what they don't have. They don't have cirrhosis. So, and F2 is awesome because Medicaid will cover it. So, woohoo, that's great, move on. I'm not going to ask any questions, but I use it for what I need it for, and that's about it.
So what's your understanding of the availability of FibroScan? Because there's a lot of people here who probably have heard of this and would like to have them in their facilities.
Access.
But
right. So I can tell you that this number's changed pretty significantly, but it increased. Like that, there used to be only like 5 in the United States because those were the 5 centers or 10 centers that were part of the FDA study to get this device approved. The last I heard, there were over 40, and I'm sure there's way more than that because most VAs have them now, and many centers. So in North Carolina, I know for a fact UNC has one, Duke has one, and the Durham VA has one. And so then the issue just becomes, so one is insurance will cover it, so it is approved. I mean, Medicare will pay for it, Medicaid will pay for it, that's great. And the question is just how to get into it. So at Duke, I don't know how it works at UNC, but at Duke, it is literally a referral. You can refer in just for a FibroScan. The hepatologist won't like snap up your patient and never let them go, which I think is a concern for many providers in the community, whether you're ID or GI or HEP. I don't want to refer them to like, big Duke or big UNC, and then they take my patient away and I can't actually treat them. So I think what I tell most providers is reach out to those big institutions, develop a relationship with that site and that group that does the FibroScan and say, I want you to just do FibroScans for me. I don't want anything else. That's actually the relationship that I have with GI now. I mean, I send my patients for a FibroScan. They do the FibroScan. They send them back to me. They don't do anything else. It's just like going to radiology and getting a test. And again, that test, if it reports out correctly, at Duke, this is how it's done. I presume at UNC, what it will give you is a number, which is a stiffness of the liver score, and we'll get into this a little bit as well in the talk. But that will say is or is not consistent with cirrhosis, which is the only way that test really should be used. There are other groups where you can kind of put in, this is consistent with F2, this is consistent with F3, but the bottom line is that test is not good enough to tell you that answer. So you have to know enough to know that when they tell you that, it doesn't really mean what they're saying.
So at UNC, we have 2 different ways to get FibroScan. So it used to be only through hepatology, through the liver clinic. So you would refer in, they would, just like Dr. Naggie was saying, you would refer in, they would do it, and then they'd send the person back. Very rarely they snatched them. It was pretty rare because they weren't enthusiastic about snatching many of the patients we were sending their way. And then radiology got one. So now we have a combination test. It's called, in EPIC, U.S. liver with elastography.
Yes.
So you get an actual image. And I think that's another important note is that FibroScan, even though it's a type of ultrasonography, it doesn't give you anatomy. So it is not by itself a screening test for hepatocellular carcinoma. It just gives you the stiffness. So Dr. Naggie's analogy is the Jell-O. So you should probably tell them I love the Jell-O thing. So.
Yeah, and I stole that from Ken Sherman, so I
Okay.
can't take credit for that. But the way that I explain this to patients, and it is, I mean, it's an interesting test. So it actually is it's a probe. And the probe emits a shear wave. And what it measures is how quickly the shear wave travels through the tissue and back to the probe, right? So, I mean, we all learned this in science class, that any, whether it's heat or sound, travels faster through solid than liquid than air, right? And a more solid, stiff liver is going to generally have a faster wave, so it's speed that it's converting to in terms of stiffness, and that's a bad sign. So what I tell patients is a normal, healthy liver is like a bowl of Jell-O. So when you tap it, which is basically what the FibroScan machine does, it measures the wiggle and jiggle of your liver. Sometimes wiggle and jiggle is good. In this case, wiggle and jiggle is very good. And I tell them that the way that scarring develops in the liver, has anyone had that Jell-O that's got like the fruit salad in it? Yeah, no one likes that. But the way that fibrosis develops in the liver literally is around the portal tract. So if you start jabbing the fruit into the Jell-O, over time it gets stiffer and stiffer. That's exactly how fibrosis occurs, and that's exactly how this machine measures stiffness. So that's the analogy I use to patients when I'm teaching them about what this test is that they're going to have. And it tends to go over pretty well.
Especially for people who've suffered through fruit and salad.
Liver
Jell-O.
biopsies, yeah.
Or the Jell-O, yeah.
Or the Jell-O, right.
So in terms of drug-drug interactions for this person, she's kind of boxed into the ARVs that she's on.
Yep.
So what considerations, so genotype 1B, would you have? I mean, she really can't do anything to her. Well, there's limited stuff she could do with ARVs.
She can do. So I would look at this and think about a couple. So one is what's off the table. So Merck's off the table, Simipavir's off the table, right? So that leaves the ladipasvir sofosbuvir regimen, the Daxoff regimen, and technically I would say it leaves the PROD regimen. The PROD regimen is one that I tend to prefer in patients that are 1B because it is near perfect, and that is because there's a protease inhibitor in it, and it's a triple DAA combination. So it probably there's more barrier to resistance in that setting. The issue is that there is a drug interaction. There was data presented at CROI that there is a decrease in darunavir exposures, but in 20 patients, those patients didn't break through. So I think that is certainly on the table. The Daxoff regimen is kind of a no-brainer if you can get access to it because you use 60 milligrams. This is where the DAC gets a little confusing. With boosted atazanavir, declatosphere does have an increase in exposure. So if you're going to use an atazanavir-based regimen, you have to use 30 milligrams. But if you're going to use lopinavir or darunavir boosted, then you use 60 milligrams. This is one of those many examples in HIV where what happens, what you can predict from one class, in particular protease inhibitors, is not necessarily going to be true across all protease inhibitors. There's not a class effect when it comes to drug interactions, in particular with HCV meds and HCV protease inhibitors. So, I mean, HIV protease inhibitors. So this is a big issue because initially in the phase 3 study, they presumed it was the same. They actually decreased the dose for all of the boosted PIs, and ultimately there was concern that maybe they actually had more viral breakthroughs, in particular in the darunavir arm, because they were probably getting lower declatosphere exposure. So in this case, it's a no-brainer, 60 milligrams, and you can get away with this. And then it gets to the lead-soft issue. Again, there's the tenofovir issue. It's a boosted regimen. I would argue, based on the recent data from EASL, it's probably safe. But in that setting, at this point in time, as of today, you would be going off-label and against recommendations by both the DHHS and the ASLD-IDSA.
And FTC TAF, I mean, would that?
Yes, so if you once TAF starts really rolling into the clinic, as everyone in this room knows probably better than I do, the exposures to tenofovir with TAF is over 10-fold lower, right? So there really isn't an issue with TAF when it comes to the ladipasvir regimen, and there is data already in healthy volunteers of that. So that's not going to be an issue once TAF kind of rolls out.
All right, let's buzz through. We have about 20 minutes left, so we'll go through the final two. So case 4 is Rob. He's a 62-year-old black gentleman who's on Medicaid. He has genotype 1A back from 2000. He was previously treated, so he was on PEG interferon and ribavirin, but had to stop it at around the 6-week mark for a pretty profound anemia and some psychosis type stuff that developed. He had a prior history of depression as well. So the interference seemed to exacerbate all of that. Hep C RNA was 3.6 million in the summer of last year. FibroSure was F4. CD4 is 380, and he's stable on FTC, TDF, and rilpivirine since 2013. He's on, the only thing I want to point out here is the milk thistle, and I'm going to ask you about that in a second. And his labs are so his platelets are not happy.
Right.
And he's Child-Pugh B, and a pre and Fib4. Everybody's concordant in this, that there's bad things happening.
Right.
So the questions about this person is, so what about the ribavirin? So clearly he's cirrhotic and could probably benefit from ribavirin being in the mix. Does his prior history with ribavirin, with the anemia and the other issues, did that steer you away from using it? Or talk about the calculus for ribavirin in the modern era.
Right.
Yeah.
I am the wrong person to ask because I love ribavirin. You know, like I said, my MO is I don't ever want to see a patient relapse, so I'm like, ribavirin, why not? You know, if you can't tolerate it, we'll stop it, but we'll do it anyway. So there's a couple of comments I would make about ribavirin here. And really, when you think about what regimen can he use, so he's a Child-Pugh B. This is critically important if you're going to start treating these patients. And if they have cirrhosis, you must calculate the Child-Pugh status. As of today, a protease inhibitor sparing regimen, none of the protease inhibitor sparing regimens are approved in patients who are Child-Pugh B. Why is that? Protease inhibitors tend to be, again, P450 driven. They tend to have increased exposures in patients with significant liver disease, and then you have a really significant concern about toxicity. There's growing data of particular regimens in Child-Pugh B specifically, but as of now, that would not be a recommendation. So what you're talking about using then, right, is a PI sparing regimen given this. And that ultimately gets you to Daxoff, where we have limited data in patients who are cirrhotic. There's the Ally 1, right, that looked at a 12-week course plus ribavirin, so plus ribavirin, and or the lidipisphere sofosbuvir regimen that has a similar study in patients who are what we'd call decomps, right? So when we talk about liver disease, I always tell patients there's a huge spectrum of cirrhosis. There's the patient, which looks like many of our patients, sitting there who look fine, who feel fine, whose labs are totally normal, and then there's the patient whose eyes are yellow and they have ascites and they're a decomp, and many of our patients are somewhere in the middle, and the Child-Pugh Bs can look pretty normal other than a platelet count, right? But this patient may feel okay. They're Billy's too. They may not look jaundiced at that point, right? And I think these patients can slip under people's radars, and these are the ones who can suffer pretty severe consequences if given the wrong regimen. So in this case, if you look at the data and where the recommendations are for a decompensated cirrhotic, these are ribavirin-containing regimens, right? If you then take a step back and you can say that the lidipisphere sofosbuvir regimen is approved in patients for 24 weeks if they can't take ribavirin, they got that approval. And so you're probably going to be able to get a 98% cure in a patient for 24 weeks with that regimen if they can't take ribavirin. So it becomes a big cost issue, to be honest with you. So I would argue that ribavirin in the setting of interferon is extremely difficult, right? Very few people tolerated ribavirin and interferon together. If you look at the data now of ribavirin without interferon and a DAA-containing regimen, it is quite easy to tolerate. There are still patients who have complete intolerance because of psychiatric disease in particular. So there's something called ribavirin rage. And I ask patients when they come in, do you have road rage? Because if you do, then ribavirin may not be the drug for you. It is harder for patients. I tell them it will. If you are intolerant, if you already have a really short fuse, ribavirin's probably going to make it worse, right? But this also gets to ribavirin at weight-based dosing. This is the other thing that we have no idea about, but if you look at the Ally 1, which was the Daxoff regimen in decomps, and if you look at the SOLAR studies, which was the lead-soft regimen in decomps, they didn't use weight-based dosing of ribavirin. They used 600 milligrams. And these patients tended to tolerate this very, very well. So my MO when I give patients ribavirin is if they're decomps, they start at 600 anyway. If they're not, but I'm using it for a particular reason, I tell them we're going to start at weight base, but we're going to have a very low tolerance for dropping dropping to 600 because my gut is we don't need weight-based ribavirin anymore. We need to do studies. There are studies going on now that look at non-weight-based ribavirin dosing because we probably don't need the doses we used to use. So I'm not very scared of using ribavirin. It does increase pill burden, and it definitely increases side effect profile. There's no doubt about it. If I wanted my life to be easy and get no calls from my patients, I would not give ribavirin. But that is not necessarily what I care about that much. What I care about mostly is my patients getting cured. So I wouldn't view this as a contraindication per se, but I'd want to know, like, what was the psych issues, what happened?
Yep.
I'd monitor the patient extremely closely. They'd have to be in good psychiatric care, at least stable from a psychiatric perspective. But I think it is very different when interferon isn't in the mix.
So milk thistle, any utility for milk thistle in liver patients?
I think it's pretty clear, randomized controlled trial saying that milk thistle does not improve anything for patients. And I will say this, for the longest time, if patients wanted to use it, I didn't really care. I do ask them to stop milk thistle when they're on treatment because there are many of these compounds in particular, and with some of the regimens, milk thistle is specifically contraindicated, right, because of drug-drug interactions with the DAAs. But ultimately, there's no benefit. There's potential drug interaction harm. I ask them to stop it. But patients want to do something, right? So all of us have our patients say, what can I do? Can I eat healthier? Can I do something? And what I tell them actually is pre and post cure is there are things that you can do to improve the health of your liver. Exercising, eating healthy, and not having fat in your liver, which correlates directly to visceral fat, is something that you can do. If you want to have a healthy liver, then you need to make sure you're eating healthy and you don't have fat in your liver, because for many of our patients, especially with HIV, liver disease will progress if that patient still has fatty liver at the end of their SVR, or the end of their cure. And the other thing that I recommend to them, and I do not get any sort of money from Starbucks or anything like that, but increasingly the data says that caffeinated coffee, 3 to 4 cups a day at minimum, is beneficial to patients who have liver disease. I think this has now come up in HIV patients, it's come up in HCV monoinfected patients, multiple cohort studies. So when patients say, what can I do? I say, you can make sure you live healthy and you can drink coffee. The only patient population I would not recommend coffee to are patients who have severe gastroesophageal reflux disease and Barrett's esophagus, where coffee is a no-no. But shy of that, I actually recommend 3 to 4 cups or more a day. And then they feel like they're doing something.
So a clinician's level of coffee intake is what you're
That's
prescribing,
correct. So just drink what I drink every day. Can you tell? I'm only on my second cup. I've got 2 more cups to go.
So if we made this person have near end-stage renal disease, and this is the other issue that in our clinic, we have a few people left that we've warehoused for a really long time because of their renal disease.
Yep.
So we were very excited about elbasvir grazoprevir. He's genotype 1A.
Yep.
So can you talk, what would you do with this person if he had bad renal disease?
Right. So I think from the renal disease perspective, there's only one regimen that's FDA approved in patients who have severe CKD stage 4 or stage 5 end-stage renal disease, and that's the Merck elbasvir grazoprevir regimen. So I always start at that, right? If you're going to start somewhere, you got to start with the FDA approved regimen, right? I go off the reservation a lot, but even in this case, I tend to stick there. The issue is that there are going to be patients. So, for example, this one where contraindicated in Child-Pugh class B, right? So that's number one. Contraindicated with rilpivirine. So I think then you either have to make some serious changes and have a really serious discussion with the patient regarding concerns for safety, or you need to think about outside the box. So in this case, the other regimen that is not FDA approved, but that is not renally cleared, is the PROD regimen. The issue is you get into the same exact issue in that this is a Child-Pugh B patient, and that is where this regimen is contraindicated. So that you can see very quickly you start to whittle down to a regimen that is not FDA approved and that is renally cleared, for which we do not have. We have increasing data for safety, but still some pretty significant concerns, and that's a sofosbuvir-containing regimen. So that's the order that I go in. FDA approved, not FDA approved, but clearly perfectly safe is the PROD regimen. And then down to the soft regimens, and I would only recommend using those when A and B are not available. The patient clearly needs therapy, and I would do it in consultation with someone who feels comfortable with that. And I'm happy to go into more detail about it regarding the sofosbuvir clearance, et cetera, and the metabolites, but you probably don't want me to belabor that point. But I think this gets really, I had a patient in my clinic. at the VA who is a liver kidney transplant. His kidney failed, so he's on dialysis. He's a liver transplant a patient who also has something else going on. I forget what it is. So, no matter what regimen I choose, I'm going off-label for one of his disease states, right? Mm-hmm. And I think these are issues. This is the real world. It's very hard. Pretty quickly, you get to a situation where you can't use the preferred FDA recommended regimen. And I think you just have to, one, educate the patient if they can understand this about the risks you're asking them to assume, and do the best that you can. I tend to feel safer using a soft regimen in an end-stage renal disease patient than I do a PI regimen in a patient with severe liver dysfunction, to be honest with you. But everyone's going to be different in that sense, I think.
Okay. Let's go into the last case, and then we'll have hopefully a couple of minutes for questions. So case 5 is Tommy. He's a 30-year-old white guy who's uninsured, and he's presenting for routine follow-up in your clinic. So he was co-infected simultaneously with HIV and Hep C in 2012 through injection drug use. He had genotype 1A with an RNA of 480,000, and he achieved SVR. So he got ledipasvir and tolerated great and did great. And so during treatment, he was switched to raltegravir from ritonavir-boosted atazanavir. And then afterwards, he said, I don't like this 2 times a day thing. Yeah. I want to go back, and I also want fewer pills. So he's on FTC and tenofovir, and then cobicistat-boosted atazanavir single tap. He's on buprenorphine naloxone treatment, and his labs are the tell-all. So he comes back in just for routine. He's feeling great, but his ALT says there's something cooking. Yeah. So what's your, this is why I said hold this thought. So what do you do for this guy? So this is the first evidence that there might be Hep C present, but he achieved SVR before.
Sure.
So what do you do?
Yep. So and in this setting, I mean, so he's SVR 12 and 24. So this is if this is HCV RNA. I mean, if this is HCV, so the first thing you have to do is check an RNA. And if this is HCV, acute HCV in particular, given his ALT, then it's a reinfection. And so treating a reinfection, you treat it just like you would any new infection, right? So it isn't like because he was treated before, you have to worry about, for example, resistance because of his prior regimen or anything like that. You are starting over de novo from the perspective of what Hep C regimens you're going to be choosing. But ultimately, whether or not you can get approval, I think no one knows for sure right now. I mean, I have had insurance companies call my patients and say, your doctor wants this regimen, we're going to give it to you. It's the only time you're going to get Hep C treatment for the rest of your life. And they actually call them on their phone. I mean, I call it bullying because it sounds really horrible, and I don't know why they'd make that phone call, but I've had multiple patients report this to me. Whether they're truly going to do that and keep track of whether or not patients are getting reinfected and they're being asked to retreat patients, I do not know. I don't see that holding up in court, ultimately, to be honest with you. So I don't really see that as being a viable path for those insurers. So I would say that, ultimately moving forward with retreatment. Now, take a step back and remember that this patient's probably acutely infected. I don't know how long he's been since his SVR 24 check. You said, did you say that?
No. So let's make it a year out.
So he's a year out, so you don't know exactly when. He still has a pretty elevated ALT, which suggests he's probably still pretty early in his infection. I think it's important to remember that some patients will spontaneously clear this virus. And just because he didn't clear it the first time doesn't mean he won't clear it the second time. And just because they cleared it once doesn't mean they'll clear it the second or third time either. So in this case, monitoring for these patients, the guidelines essentially suggest that you should give these patients at least 12 weeks to attempt to spontaneously clear. And ultimately, you get the biggest bang for your buck in terms of spontaneous clearance if you wait between 6 to 12 months. So if we used to say 12 weeks, but the reality is the more recent data is if you just go 12 weeks, only 25% of those who are going to clear. If you go 6 months, 67% of those who are going to clear. That's probably your biggest bang for the buck in terms of the balance between delay and treatment. And if you wait a whole year, then it's over 80%. So I think it's somewhere around 85 to 89% of those who are going to spontaneously clear will clear. So what the guidelines say is if your patient and you are willing to monitor and wait, your biggest bang for the buck is year. Or 6 months, and then ultimately, how do you treat him? You treat him just like you would if he was chronic. And I think if for those who are going to the cases in the afternoon, we will discuss an acute case. And ultimately, there is some data now coming up of whether or not acute patients can be treated differently than chronic patients for HCV. You know, historically with interferon regimens, they had higher SVR rates and shortened courses of therapy. You can't get higher SVR rates than 98, 99%, but can you actually shorten therapy in these patients and give them 4, 6, 8 weeks instead of 12 or 24? But I think that right now the data does not give us a great answer, so the guidelines still say that if you want to treat this patient, ultimately you treat them as chronic, which is giving them, you know, whatever regimen you can get your hands on that you would treat for a chronic patient. And that's kind of what you do for this guy, I think.
Great. So we have a few minutes for questions about any of the cases or general management stuff, so jump in. Yeah.
So that's a great question. Certainly, patients who are exposed
Can you
over and
repeat
over again.
Can you repeat the question, Susanna?
Oh, sorry.
Yeah, sorry.
So I think the question was, in patients who get infected and then spontaneously clear, are they more likely to kind of fight off the second infection or the third infection? So just because you spontaneously clear does not mean you're more likely to clear the next time. But what we do know is of those patients, they are frequently exposed to the virus. These are usually really high-risk patients, in particular IV drug users. And they do seem to have some higher level of immunity, but that is not, there is a glass ceiling to that immunity, meaning sooner or later those people can get and will get reinfected. It's a little bit of a game of Russian roulette, so they may have fewer bullets in the chambers, but ultimately it's going to happen. So it is definitely not a universal, if you cleared the first time, you'll clear it again. That does not happen. In fact, we've had patients who have spontaneously cleared a virus and gotten reinfected by the same partner, and then the second time around, same exact virus, they develop chronic infection. So definitely not something for a patient to bet on.
Other questions?
Yeah. So it has to do with the genetic variability. So this is for an audience that looks at HIV. It's the same reason we don't have a universal flu vaccine, a universal HIV vaccine. HCV virus, in terms of human viruses, replicates more rapidly than any other human virus, and it does not have the ability to proofread. So it also mutates more quickly in its genome than any other human virus. So the variability of the parts of the virus that our bodies develop immunity to changes so quickly that we cannot develop true neutralizing antibodies. That's the bottom line. So it's the same challenge that we see in HIV and HCV vaccine development is the same challenge our bodies are dealing with as well.
Yeah.
And you have to use the third line, which is soft. Do you use standard dosing or do you adjust dose to that?
Right. So again, this is not FDA recommended.
So can you repeat the question? Sorry.
Oh, yeah. Oh, yeah, sorry. So the question was, if you ultimately have to use a sofosbuvir-containing regimen in a patient who has severe CKD. So remember, sofosbuvir is recommended by the FDA down to a GFR of 30. Once you get below 30, there is concern for, in particular, increased exposures to the metabolite of sofosbuvir. So sofosbuvir itself, when you look at patients who are dosed 7 hours later, you actually don't detect, less than 10% of what you detect in the bloodstream is sofosbuvir. Most of what you detect is its inactive metabolite. The question that no one knows is the inactive metabolite dangerous? Now, what I can tell you is hundreds of patients have been dosed with sofosbuvir. The drug itself is in FDA-guided safety trials, right? So they dosed 10 patients initially who were severe CKD with 200 milligrams, which is half the FDA-approved dose. Those patients did not do well from a SVR standpoint, but from a safety standpoint, no one dropped dead. And I think when it comes to a nuke, everyone's concern clearly is regarding cardiotoxicity, right? So the first nuke that went by the wayside, gave rats heart failure. So ultimately, everyone's concern would be in that sort of picture, lactic acidosis, something of that sort. So that was safe. So then they moved to the 400 milligram dose. Again, safe. Now they're looking at the lead-soft combination in patients on that are end-stage renal disease, and that's the 400 milligram dose, right? So just at EASL, there were multiple kind of multi-center, kind of real-world cohorts of using both the 200 milligram dose and the 400 milligram dose, I use the 400 milligram dose. To me, the difference of like 15-fold versus 25-fold increased exposure to the metabolite is no different. If the metabolite were really that unsafe, 15 to 20-fold should show a safety signal, I would argue. So the fact that the FDA is letting this dosing go on and hasn't ended dosing is enough for me to say I'm okay with doing this. But again, this is in my clinical practice. This is way off the reservation. But ultimately, it's about, like, I have a patient who has liver cancer and keeps getting recurrent HCCs like every 3 months. And I could give him nothing but a sofosbuvir-containing regimen. And I felt like my hands were tied. I could either do nothing, which I'm sure you could all tell I don't like to do, or I could do something, and it was education for the patient. So I go 400 milligrams. And a lot of European groups do 200. But what the FDA is letting the company move forward with is 400. So that's kind of where I stand on that. Yeah.
I think that's all we have, unless you want to have questions afterwards. But thanks for your attention very much. Appreciate your coming to this session.